So my name's Stephen Carra. I'm a sport and exercise physician, which means that basically I'm a sports medicine specialist, for those that don't know the profession. I'm a GP as well. I worked as a GP in South Auckland for about 12 or 13 years, I think, before sports medicine took me away, and I had an interest in sports medicine and went down the sports medicine pathway. So I enjoy coming and talking to GPs because I still value my GP fellowship. I asked to talk about paediatric concussion. So in the sort of allotted time, I'm going to kind of quickly move through what I think are maybe some valid things that you can take to the practice on Monday. And through the questions, come back to the things that I might have missed for you. All right? So let's start with what is concussion. Concussion, for me, is a transient disturbance of neurological function. There's a couple of really key points to that. Number one is transient. Okay, so transient, as you well know, means that things get better with time. And that's sometimes lost, and it's lost due to probably media popularity around the long-term effects of concussion. And while I haven't addressed that in this, we can come back to that in the questions. And the second part is function. Okay, so it's not a disturbance of brain structure. So that's why imaging, and often kids and adults will have some imaging because there's concerns that they may have an underlying structural pathology. And for those of you who've seen the discharge summaries from EDs, you'll realise that most of the CT scans are normal, okay, because it's not a change in structure. It's a disturbance of brain function. And one of the things I tell my patients when I see them, it's like taking a photo outside their house. If I take a photo of their house, I can tell them that the guttering needs replacing and the weatherboards need painting. But it doesn't tell me what's going on inside the house. And that's where we are at with use of imaging in concussion. Yes, there are some more functional MRIs and DTIs, but they are very much research tools, and resource means we just will not be able to get them to the community in any quick shape or form. So a change in neurological function or a change of function. And if I ask my athletes, when I'm working with athletes, they will tell me the number of times they've been concussed means the number of times they've been knocked out, okay? And there's no correlation because only 10% of people will present with actually being knocked out or having a loss of consciousness. And as you can see from some data that I pulled from the brain health study from Australia this year, it's quite, 1 in 5 children by the age of 10 will have experienced a concussion, and about 20% of those are in sports, so 80% are not. They're playground things, they're home things, they're falling off my bike, etc. And it's the things that are internal or innate in children that make them slightly higher risk. Higher risk means slower recovery. That's why we're more cautious with them. And that's the things around myelination, it's around brain size, and probably some extrinsic things around lack of neck strength. So a child comes with concussion. One of the things I want to know, the three things I want to know is, 1, do I need to send them to the ED? 2, do I need to refer them to a specialist service? 3, can I manage them myself? Right? Those are the three things that I'd want to know sitting in my primary care. So you've probably seen this slide before. It's what we call the red flags. You're probably all very knowledgeable about this. If on the left-hand side of that slide, there's a really good pocket card that ACC give out, and it's free. I actually think it is actually quite good. And no, I don't do any work for ACC, okay? So if you're looking after teams or you're involved in some sideline sport or you're seeing a lot of these things, then I think that this card is something you can have. You can hand it to a caregiver, hand it to a parent, and say, these are the things that we need to watch for, okay? And it gives them some very simple advice. So most of those on those lists are pretty common. They're pretty common sense. The one I've highlighted in red is the one that I think was absolutely no help, because it says repeated vomiting. What's repeated vomiting? Well, once, twice, 3 times, 5 times, how many times? And actually the literature can't help you here, all right? So you've got to put your line in the sand about your comfortableness. For me, when I'm looking after these athletes, 1 vomit in an adult is acceptable, none in a child, okay? There's no data around that. That's just my comfortableness, all right? You may be more comfortable having 1 vomit in a child and 2 in an adult. I guess when they're coming to see you, if they vomited on the day and they're getting better now, then that's probably okay. If they've vomited a couple of times and the parents think they're not getting okay, then that's probably not okay. All right? So have a level of comfortableness that you're willing to do in the surgery, right, to say what is repeated vomiting. The other thing is loss of consciousness for 5 minutes. That's a really, really long time. All right? Okay, second one. You've decided who's going to go to ED. Who am I going to keep? Who am I going to refer on? There's an article we wrote in BPAC last year that I think sums up what I'm trying to say here. Right? There's a way to risk stratify people. We can get way smarter than we used to be. Right? Risk stratify people, who's going to get better quicker, who's not going to get better quicker. It's based on symptom clusters, it's based on symptom load, symptom burden, it's based on previous history, it's based on concussion modifiers. And out of this, there's a thing called the BIST, which some of you may well be familiar with, some may not. It's called the Brain Injury Surveillance Tool, screening tool. It comes from Alice Theodem out of the AUT, and what we've done is we've taken the SCAT5, the Paediatric SCAT5, and we've shortened it down, and it's aimed at primary care. Why is it aimed at primary care? Because it takes 6 to 8 minutes to complete. It gives you a number, and we're about to just change it and weight it so that different things have different weightings. And on that number will tell you this child is likely to get better within sort of 2 to 4 weeks. This child is not likely to get better and may well need to be referred on. Vis-a-vis, you can use the same thing for your adult patients. So the tool will tell us on risk stratification, you might decide to send that person to a specialist service because they're high risk for a prolonged recovery. Those ones you want to keep, you need to educate, and the first 24, 48 hours is relative rest, and then it is controlled physical and cognitive loading. This is a slide of a guy called John Leddy, who I met decades ago, and there's a thing called the Buffalo Concussion Treadmill Test. It's a cardiac test, and it's designed to increase person's heart rate through a various range of workload range, to make them symptomatic. Why do I want to make them symptomatic? It's because I want to see what their heart rate is when they become symptomatic. And then I take 90% of that heart rate and I exercise them on what I call a sub-symptom threshold, underneath where they get symptoms. Again, why do I want to do that? Exercise produces a hormone called BDNF, brain-derived neurotrophic factor. It assists with neural recovery. Doesn't come in food, doesn't come in an injectable form, it comes through exercise. So controlled physical loading means I want them to exercise, I want them to make the hormone, but I want them to exercise at a level that doesn't make them feel terrible. What does that mean for kids? Let them go outside, let them play, let them do the normal things, because if you're a parent here, they're going to drive you crazy sitting inside, all right? Let them go and shoot hoops, let them go and kick a ball with themselves, not with their friends. It's not a contact type thing, it's not a match, all right? Let them be active and let them symptoms, all right, drive where that threshold is for you. This is the other slide that I use. Controlled physical and controlled cognitive loading. So from a cognitive perspective, we want them to do things, all right? This is one study, it's quite a complex study, but what it showed, actually, if they get off their electronic devices, all right, they get less symptoms. Surprise, surprise, all right? But I quote this all the time, because I think children are now born, the first thing, it used to be the head crown first, I think it's the hand with the phone nowadays that crowns first. But they're all born with them. You've got to get them off their devices early, because it reduces their symptom load. As a parent, it makes your life a lot easier. Okay, and then you introduce that after they've introduced schoolwork. Okay, for me, electronic use is around education, not around social media, and that's the thing that gets reintroduced first. So I use this study quite a lot. Controlled cognitive loading means a return to learn program. Okay? There are lots of ways of doing this. This is one way. This comes through the concussion and sport group. Okay. The second way is, this is a new one coming out of the UK concussion grassroots guidelines. It's all about controlled loading. Reintroduce things slowly, okay? So that for me, if the child has 1 or 2 days at home, that's perfectly fine, but they're doing some cognitive stuff at home. Some work comes home, right? Doing nothing is the very wrong thing. So I call this the Goldilocks factor, and you've probably heard about this, and this is how I talk to my patients around controlled cognitive loading in particular. Everything's a U-shaped curve, right? If you do too much, you will feel horrible and it will take you longer to recover. If you do nothing and you lay on the couch and you watch movies, you won't feel that horrible, but it will take you longer to recover. So you need to find the sweet spot. The sweet spot is different for everyone else. I do not give my patients, you can spend 10 minutes doing this or 20 minutes. That's just a random number. Everyone's variable. Just train it to the individual, all right? Talk to them about their symptoms. Use a simple visual analog scale. Rate yourself out of 10 before you start going onto your computer to do a little bit of your schoolwork or whatever, before you start reading. If you're 5 out of 10, then I'm happy. That's your sweet spot. All right, you've got some symptoms, you've had a concussion. So long as they stay there, then I'm very happy that they can continue doing their cognitive loading. If it increases by a factor of 3, so I'm 6 out of 10, I'm okay, 7 out of 10, but now I'm 8 out of 10, that is my threshold. All right? So it's a very simple way of passing over to the parent, passing over to the child, how they can monitor their own symptoms and how they can manage their own symptoms. And it ticks the box for me for around controlled cognitive loading. So whirlwind talk, sorry. So the take-home messages from me: make a clinical diagnosis. There is nothing that is going to help you from an imaging point of view or from any biomarker point of view. Risk stratify my patient. Who is going to get better quicker? Who needs to go to ED? Who can I look after? The group that I can look after, how am I going to do that? Education really early. Tell them it's a transient disturbance of neurological function. 70% of people will get better within 4 weeks. Give them some time frames, okay? 24, 48 hours of relative rest, controlled physical and cognitive loading. Let their symptoms be the driver of what they can do. Give them the management plan. Use the symptom scores. If you're going to use the BIST or you use SCAT, just use the symptom scores to monitor recovery. All right? That's the most helpful thing. And then return them to school before you return them to play. Whirlwind talk. Thank you very much.